Essentials of Health Information Management, Principles and Practices, 2nd edition, Chapter 3, Healthcare Settings. The objectives for this presentation: list and define hospital categories and identify types of hospital patients. Differentiate among freestanding, hospital-based, and hospital-owned ambulatory care settings. Distinguish among various types of behavioral health care facilities. Detail services provided by home care and hospice agencies. Explain the various types of long-term care. Differentiate among the various managed care models. Describe federal, state, and local health care facilities. In previous lectures, we talked about the continuum of care. In this lecture, we're going to look at the different healthcare settings in which healthcare services can take place. To begin, we will look at acute care facilities. Acute care facilities are, in other words, hospitals. They take care of acute illnesses that a patient may come in with. And you can see single hospitals or multi-hospital systems that exist. If you have a single hospital, it's a standalone. It's not associated with any other type facilities or other hospitals. But then there are also what we call multi-hospital systems, in which they are all under one umbrella. So maybe they have, I think the hospital in Thomasville is under a multi-hospital system. So there are several hospitals in different areas that all fall under the same leadership umbrella. So you have single hospitals and multi-hospital systems. You can also see in acute care facilities, quote-unquote hospital, they have ancillary services available. These usually include your diagnostic and your therapeutic services that can be on an inpatient or outpatient basis, like your laboratory or your physical therapy. Now, when we talk about inpatient stays, they can be either acute care or short-term care or long-term. If it is an acute care short-term, then it's usually less than 30 days. However, with your acute care or your hospital care, it's very expensive. It's pretty much at the top in terms of costliness in the continuum of care. You have medical and professional staff to oversee those inpatient beds in a hospital. You have certain hospitals that serve specific populations. For instance, you can have a children's hospital, right? And so that will be a hospital that just specializes in the treatment of kids or children. You also look at hospitals in terms of size. And when we're looking at hospital size, we look at bed count or bed size. And basically, this is the number of beds a hospital can hold in reference to their license. So when they are licensed with their state, they already specify how many beds that they can have. Once this is established, then all of their equipment and their staff has to be able to support that number of beds. We also look at, in terms of hospitals, is the length of stay of the patient. And we kind of mentioned that already in terms of short-term and long-term. And we looked at that less than 30 days. Long-term is usually greater than 30 days. We call that length of stay for a patient. Okay? Now, there are exceptions to that rule. So the average is 30 days, less than 30 days if they're short-term. But there could be instances in which a patient may stay longer. And the same thing on vice versa. Now, in terms of hospital categories, you have different types of hospitals. One would be your critical access hospital. Critical access hospitals, in order to be deemed that, they have to be located more than 35 miles away from any other hospital or another critical access hospital. Again, there's an exception to this definition. They can get away with being 15 miles away if they are in a location in which you can only reach them through secondary roads, or if they are in some type of mountainous terrain, then they can be 15 miles versus your 35 miles. But they're really for like rural areas in which people can come in and get services. They can't have any more than 15 inpatient beds unless they have swing beds. And with swing beds, what they are is your beds change in terms of what they're used for. So if the critical access hospital is in use of swing beds, then they can have up to 25. All right? But they can have no more than 15 at any one time for acute care services. And they only can have 96-hour stays. They can't go above and beyond that unless there are some unusual or exceptional circumstances. Now, other types of hospitals, you have your general hospitals. Those are just what it means, general. They take in all patients with the services that fall under their purview in terms of acute care. You have specialty hospitals where they're looking at a specialized population, like we mentioned, children's hospital or cancer hospital or something of that nature. Your rehab hospitals, those are inpatient care, but they have patients in which they're trying to restore their function back to them, get them to some level of function that they previously had. You have also behavioral health care hospitals that deal with mental health diagnoses. Those are the type of patients that they see. Now, your book also talks about a concept called hospitalists, and basically hospitalists are physicians that they are in that hospital setting and they admit patients to that hospital from the primary care providers out there in the community. We call those hospitalists. Now, when we consider the types of patients, you have different types of patients, and it goes along with whatever setting those patients are receiving their care from. You may hear the term ambulatory. Ambulatory is outpatient. That's the same thing. So you can have an ambulatory care setting. You also have ambulatory patients, or in other words, outpatients. Ambulatory surgery patients, these are those they have surgical procedures that are on an outpatient basis. And when we say outpatient, your formal definition is that they're not staying overnight in the hospital. Their length of stay is a maximum of 23 hours, 59 minutes, and 59 seconds. So just below 24 hours, which will make you an inpatient. So these are our outpatients. So you got your ambulatory patients or outpatients and your ambulatory surgery patients, where they receive surgery on an outpatient basis. Your emergency department in your hospital, although it may be attached to the acute care facility or hospital, it is deemed a outpatient type facility. And you know your emergency care is for those patients coming in with urgent needs. We've already talked about inpatients. Those are they that stay in acute care type facilities. They're staying overnight, so it's going to be 24 hours or more. You have newborn patients. Those are infants. Either they are born there at the hospital, they could be in the neonatal intensive care. These are, well, basically, in terms of when you're doing statistics and stuff, the newborns are those that are born in that hospital. Now, observation patients, you have a area in the hospital where maybe they come in through the emergency room or something of that nature, and they're trying to figure some things out. They don't have everything quite concrete, and they're trying to figure out, should we send this patient home? Do they need to be admitted? And so what they will do is put them on observation status. And this is where they're going to monitor them. They will occupy a bed while they evaluate their condition. All right, so these are called observation patients. So they're not inpatients at that point, okay, unless they formally admit them to a hospital or acute care, then they will be an inpatient. Now, your subacute care is a specialized long-term acute care. And this type of care is for your seriously ill patients. It sort of resembles like a mini intensive care unit, and they offer different services to care for those, but it's not going to be as extensive as an acute care facility. Your subacute care is not going to be as costly as an acute care. So a lot of times, the way the continuum of care works at this point, a patient does not just stay in the hospital. Once their level of care drops low enough, they're going to move them down to a lower level of care. Subacute will be considered a lower level of care. It's less expensive than your acute care. Now, we talk about what ambulatory, or in other words, outpatient care is. Here are some examples of those types of facilities. We talked about your ASCs, your ambulatory surgery centers, freestanding. We do have one or so in Tallahassee. You got your emergency departments, that's outpatient, ambulatory. You got public health department. You have urgent care centers, clinics, physician offices, neighborhood health clinics. Anywhere you're not staying overnight is going to be your ambulatory outpatient care. Table 3.1 in your textbook list these out, because I didn't hit on each one of them, and they also give you a definition of those types of facilities. So I would like for you to go through and review that. I'm not going to read through all of those. Now, there are also some other types of healthcare settings that we can consider. Your behavioral health care facilities, of course, they provide services for mental health, psychiatric type things, and you can have different types. You can have your inpatient as well as outpatient. So you have a variety of settings that patients can receive behavioral health care services. Table 3.2 really describes a lot of those. You got your hospital, behavioral health hospitals. You have residential treatment facilities. You got chemical dependency programs. Again, you can look at this table and look at a couple of definitions for these different ones. All right, home care and hospice. With your home care, these are patients who receive healthcare services from their home. All right, and so your physician will provide an order in which they can receive those at the home, and you can have your skilled professional come in and provide some of that care. They can get IVs, tube feeding, wound care, all those type of things can be provided in a home care setting. Your home health also covers your DMEs, your durable medical equipment. That's like your wheelchairs, your walkers, your canes, your crutches, and those types of things. They can get chemotherapy, drug therapy, pain management, all these types of things. Now, with your hospice, this is care for people who are terminally ill or terminally ill patients and their families. And pretty much their focus is going to be on palliative care rather than curative, meaning they're just trying to make that person comfortable. They're no longer trying to do anything of a therapeutic nature because they're terminally ill. So we just try to keep the pain down, those types of things. You can have hospice care provided in the home as well, and you can have specialized professionals who come in as well as volunteers. A lot of times you'll see cancer patients who receive those services more often than not. They also have services for the families of that terminally ill patient, like respite care. Okay. Long-term care, this is greater than 30 days. We talked about acute care being less than 30 days. Long-term care usually is greater than 30 days. You'll see a lot of your elderly patients usually taking advantage of long-term care, like in your nursing homes. But, you know, young people can also, if they're in a bad accident or some type of extended illness, they can also receive long-term care services. Other settings that fall under that long-term care, you'll see is like your adult daycares. You got assisted living facilities. Assisted living facilities, older individuals, a lot of times, if they kind of want some independence, but they also need some support, they can stay in these assisted living facilities and they like pay rent. And then you'll have individuals who come in and try and help them out, maybe with some what you call daily living activities, maybe helping them with their meals, house cleaning, so forth, that kind of thing. But with those individuals, they don't need some serious care, so they're a lot, that gives them the ability to still have some type of life. You also have continuing care retirement communities that also fall under long-term care. They could be in apartments, or they can be associated with skilled nursing or SNFs, or some type of nursing home facility. You got immediate care facilities that assist your developmentally disabled people. They have different activities and educational services. They provide recreation for them. They also help them with their activities of daily living. So we call it ADLs. That's like housekeeping and meals and things like that. Long-term care hospitals, length of stay greater than 25 days, and they provide extended care to the patients. You got residential care facilities. They can be in like a single family residence where they try to create some type of home environment or retirement residence, including nursing homes. They do work on work on assisted daily living activities, but they do not provide skilled services like injections or colostomies or things like that. So they don't have a healthcare component involved in your residential care facilities. Your SNFs, your skilled nursing facilities, are a nursing facility. They do provide medical care to inpatients on a daily basis, like your IVs, rehab, and so forth, wound care. And a lot of times you'll have your acute care. They'll transfer out of that and go to a SNF of some nature because they're not able to return home right after they are discharged from an acute care hospital. And then after they go to a SNF, they may be transferred to a rehab facility, or maybe they are ready to go home. The rehabilitation facilities, of course, these are they that work on reviving their functionality of a patient. Maybe they were in a bad car crash or some nature, and they have to rebuild, maybe trying to walk again or something like that, or they have a spinal cord injury or stroke or something of that nature, and so they will be eligible to go to a rehab facility. Rehab facilities can be freestanding, like HealthSouth, or they can be attached to maybe a hospital or something. I think PMH has a rehab facility, but in order for them to remain a rehab patient, they have to be able to follow a rehab plan where they're going, I think, to rehab 3 times a week or something. They have an amount that they must at least do, and they have to continue to make progress, or they won't be able to stay at a rehab facility. I'll talk about managed care a little further down. And I think I already talked about behavior. I might have got ahead of myself, but so I think your table, let's see what table, your table 3.2, this is the list of your behavioral health care settings. I got the slide out of order, but we talked about those, the ones I kind of mentioned through there. Just look at your table 3.2 and you can get definitions for each of those, your chemical dependency, your day treatment programs, home health, all of those are listed in that table. And here are some more continued behavioral health care settings. So here's hospice. I really did get out of order. I guess I was talking a little too fast and too much. And we talked about the palliative care being their primary goal. And most of the time they get their care from at home. Here's our long-term, the ones I was talking to you about that's included. And of course your long-term care is greater than 30 days. And assisted living facilities, your long-term hospitals, skilled nursing facilities, I've already discussed those. Here's the slide to go along with those. And now here is the managed care. So managed care is not a healthcare setting, more so than it is a concept. When we talk about managed care, we're looking at their focus. Their focus is on controlling healthcare costs and quality. They usually have some kind of gatekeeper that directs or coordinates the kind of healthcare services that a person will receive in an effort to control that cost. All right, and we call that utilization management. They want to make sure that the services that are being received are medically necessary and appropriate. And HMOs, when we talk about managed care, one of the first things people think about is a HMO, a health maintenance organization. But of course, managed care, like I say, has really moved well beyond just talking about an HMO. They're talking about utilization of services. But with an HMO, it is considered a managed care organization. And they have different types or models for HMO. If you look at your table 3.3 in your textbook, you see that a HMO has, like, for example, a staff model of a HMO. With a staff model, all of your physicians are employed by the HMO. You'll see an example of that in Tallahassee under CHP. They have that. Like, I can go get my eyes checked, and those doctors are employed by CHP. You have group model HMOs where you have a physician group that will contract with the HMO to see those patients. That would be an example of a group model. You have network models, 2 or more physicians, multi-specialty group practices provide contracted healthcare services to subscribers. So they're not necessarily owned by the HMO, but they have a contract with them to see their patients. Then you have a direct contract model where your individual physicians in that community deliver contracted healthcare services to subscribers. And you got your IPAs, your individual practice association. They negotiate HMO contract, and then they manage that capitation payment. A capitation payment, that means that HMO pays them a lump amount based on how many heads that they see that falls under that HMO or that are have that particular HMO. All right, so it doesn't really matter how many times that patient goes to get those services. They're going to pay a certain amount per head. That's called a capitation model. Now, besides the HMO, there are other managed care models. You have your point of service plan model, where the patients can use any of your providers on their HMO panel, or they can self-refer to a non-HMO if they prefer. That's your POS. Your PPO is a physician network. and in the hospital they all come together and contract with the insurance company or the employer or some other organization and say that they're going to give health care to this particular population of patients. You got a cafeteria plan where the subscriber or the employee can have choices on which type of plan they would like. So just kind of like in a cafeteria, I want this and I want that. That's the cafeteria plan. Another one I don't have on here is your EPO. That's your exclusive provider organization, where the people or the subscribers to that insurance, they have to receive services from the providers on that network who contract with that managed care organization. All right. And then you also have an integrated delivery system, and they have different names for that. That's in your table 3.3 as well. You have an organization that's affiliated of an affiliated provider site, and they offer joint healthcare services to their subscribers. So you might have a group. So you might have a hospital as well as a physician office as well as an ambulatory surgery center. They all group together, and that patient utilizes those services within that group. So the important thrust about managed care is that the services have to be medically necessary and appropriate in order for the services to occur. And so they have that person or that mechanism to make sure that that happens. And that's what managed care organizations are about. Now, federal, state, and local health care. Under this umbrella, you have your health care that occurs in your correctional facilities, and you don't tend to, when you think about correctional facilities, that's not the first thing that comes to mind, but those inmates do have to receive health care. So a lot of the health care is provided on site at the correctional facility, but they do also have other mechanisms if the services provided there or the professional staff is not able to take care of a certain illness or a situation that's going on with that inmate. They have federal medical centers that they use, and they also can use the community hospitals and stuff. It's set up in such a way, they have areas in there in which they secure areas in which they can take care of inmates. So that is another setting. Even with your correctional facilities, they are able to get accreditation if they wish. Accreditation, of course, is voluntary. One organization in which they can receive accreditation is through the National Commission on Correctional Healthcare, NCCHC. So they can go through. They have an external peer review process, and that organization, that institution can meet those standards for health services. And your book actually outlines some of the things that they look at if they want to go through that accreditation. Now, Commission also has standards set out for correctional facilities as well. They can look at that. Also, under your federal, state, and local umbrella, you got your military. That those people who are in the military are veterans or whatever, they have different mechanisms for their health care as well. So there's a military health system. You got your active military. Then your veterans, like your VHA, your Veterans Health Administration, also provide services. And you got your Veterans Integrated Service Network that provides healthcare services at VA medical centers. So you have a host of healthcare access and settings for your military. This actually is your figure 3.1 in your book on page 65, showing you a map of TRICARE regions. And TRICARE is some insurance that's provided to the military, healthcare insurance. Okay? But going back, let's see, there we go. U.S. Public Health Service. I want to talk a little bit about that. I think this is going to be the last concept I'm going to cover. The Public Health Service, what it is involved with is they carry out different programs on a national scale. They're looking at trying to find ways to prevent disease and injury. They look at the efficacy of drugs and medical devices. They deliver health services to federal beneficiaries and furnish health expertise when we're in times of war. They also coordinate other activities with other agencies, federal agencies, and they are oversaw by your Surgeon General. And so some of those other activities that they are involved in is like your TANF, your Temporary Assistance to Needy Families. Some people may be aware of that. It's a state federal welfare program. Your Administration of Aging, they help coordinate activities there. They also are involved in quality research through your Agency for Healthcare Research and Quality, looking at outcomes. Agency for Toxic Substances and Disease Registry, where they're looking at preventing exposure to hazardous substances and waste sites. Your Center for Disease Control, they are concerned with preventing outbreaks of diseases on a public scale. Your CMS, they coordinate activities with them. You got your Children's Health Insurance Program through your CMS. Your FDA, your Food Drug Administration, they coordinate activities within there. I mean, you know, the FDA is focused on safety of food and cosmetics and drugs and so forth. You got your Health Resources and Service Administration that provides health resources for underserved populations. And then you got your Indian Health Services, where they look at providing services for your American Indians and your Alaska Natives. National Institute of Health. It's a medical research organization where they research specific diseases like AIDS and Alzheimer's. And finally, you have your Substance Abuse and Mental Health Service Administration. All right, looking at quality and availability for your substance abuse prevention, addiction treatment, and mental health services. That kind of is your healthcare settings in a nutshell. So we went from outpatient to we went from acute care to ambulatory care, long-term care, and then we looked at different settings on a federal, state, and local level. We also looked at a concept called managed care. Okay, and so that will wrap up our presentation on Chapter 3.